Okay, so good morning, good afternoon, good evening, everyone, and welcome to the ACNS ISMINS webinars. And today we have three speakers today. The first speaker is Professor Masaki Taniguchi, who is the Director of Hospital Osaka Neurological Institute, Osaka, Japan. His topic today is anatomical and clinical demonstration of the endoscopic and the nasal 𝑇𝑟𝑎𝑛_SLAC approach to the paramedian skull-based lesions. Our second speaker today is Professor Milin Dionaka, who is the Professor and Head of Department of Neurosurgery, Institute of Neuroscience in Kolkata, India. His topic is neuromodulation, present and future. The first speaker is Dr. Tarasu M.O. Ahmed, who is the Head and Consultant Neurosurgeon of the Department of Neurosurgery, IMED Lima University Hospital Neurosurgery Department in Sudan. His topic is endoscopic removal of impacted suprasellar bullet in pediatric patients, a case report. Today, our chair is Professor Alexandre Monsiek, who is the Professor, Chief of the Neurosurgical Center and Clinical Hospital of Theophania and President of the Kenyan Association of Neurosurgeons. He's also the Associate Professor of the Department of Neurosurgery in the Supik National Healthcare Universities. Our discussion today we have Professor Ashra, with the Chief of Neurovascular and Neurovascular Therapy Center and the Department of Neurosurgery, Faculty of Medicine of Universities Agana and in the Surabaya. And the second discussion is Professor Asmin, who is the Head and Senior Consultant Neurosurgeon in the Department of Surgery in Tunku Hospital, Kuala Lumpur, Department of Pediatric Neurosurgery, and Hospital Tunku Asia Women and Children Hospital, Kuala Lumpur, and the Head of the Neurosurgical Services and the Ministry of Health in Malaysia. So without further delay, shall I hand over the floor to the chair of today, Professor Alexandre Monsiek.
Okay, dear colleagues, dear friends, can you hear me? Is it okay?
Okay. Yes.
Dear colleagues, dear friends, let me go on our session. Organized by Asian Congress of Neurological Surgeons and together with the International Minimally Invasive Neurosurgical Society. I invite our first speaker, Professor Masaki Taniguchi, with a very interesting and very complex topic. He will present the anatomical and clinical demonstration of the endoscopic endonasal 𝑇𝑟𝑎𝑛_SLAC approach to paramedian skull-based lesions. Please, Professor Taniguchi, auditorium is ready.
Thank you, Chairman. Ladies and gentlemen, I feel very honored to have the opportunity to speak my topic on this webinar. Can you see the slides?
Yes.
Yes. Okay.
Yes, we can see it on the full screen. Yes.
I close. Okay. My topic is about the anatomical and clinical demonstration of the endoscopic endonasal 𝑇𝑟𝑎𝑛_SLAC approach to paramedian skull-based lesions. The endoscopic approach to paramedian skull-base can be divided roughly into three according to their heights. So the most upper part is upper petoclavian lesion, which can be approached by circumventing the carotid artery, paraclavian carotid artery. And the most lowest part is approach to the occipital condyle. In this approach, the torus tubularis has been resected and rosomura fossa mucosa has incised and approached. So today's topic is middle part, approaching to the lower petoclavian area. To approach this area, we use the space between U-section tube and the horizontal portion of the petrous carotid artery. We term this space as a super U-section triangle. And as this approaches through the anterior part of the foramen rostrum, we call this approach 𝑇𝑟𝑎𝑛_SLAC approach. This is the dry skull. As you can see, the inferior petal clava area exists between the jugular tubercle and the jugular foramen, and by approaching this area from anterior root, the foramen rostrum anterior part has to be first. Some anatomical study has already been performed by Dr. Osawa, and as you can see, at first, to approach this 𝑇𝑟𝑎𝑐𝑒 approach, one has to perform at first transpterygoid approach. And to perform this transpterygoid approach, there's some obstacles such as middle turbinate, and one has to enter the maxillary sinus. And after that, the palatine bone has to be exposed, and by resecting the palatine bone, the pterygoid bone can be exposed, but in front of that is pterygopalatine fossa, and those landmarks such as Vigan canal and foramen rotundum can be exposed. Here on the dry skull, you can see the Vigan canal and foramen rotundum. This is a robust landmark during this approach. And after that, the video nerve can be cut, and also in some cases, greater palatine nerve has to be cut to reflect the content of pterygopalatine fossa superlaterally to widen its entry into the deeper space. This is an anatomical dissection. Middle turbinate has been cut, and at morbula and in the process, the middle turbinate is already exposed. Here the mucosa is dissected further laterally, and this is the dissection of the palatine bone, and also that's already the pterygopalatine fossa is exposed. Going further laterally, the maxillary sinus is entered here. Still there is bone in content. This is residual of palatine bone. This can be also resected. And going deeper, here is the Vigan canal and foramen rotundum, and the bone between them has to be resected to go deeper in the lateral recess of the sphenoid sinus. Here it's shaded at red here. Here the further the palatine bone is resected, the pterygopalatine here the V2 is exposed. This is a transpterygoid approach. This is a clinical case of a epidedmoid occupying the mechascapes. This is a recurrence case. Here the posterior part of the middle turbinate is excised, and also the mucosa incised further laterally, and here the maxillary sinus is entered and the palatine bone is drilled out. The residual bone is further resected, and this palatine foramen. And going deeper is the Vigan canal and foramen rotundum, as already shown in the anatomical study, and reflecting them laterally, the bone is exposed, and this part of the bone has to be resected to go into the transpterygoid approach. And transpterygoid approach is a gate to go deeper, further into the mechascape, infracavernous sinus, and also jugular tubercle and occipital condyle, and the paraperineal space and infratemporal fossa. And after performing the transpterygoid approach, the translateral approach can be performed. After entering the lateral recess of sphenoid sinus, one can expose those anatomical structures like carotid artery, video nerve, and the Eustachian tube. And this is a separate Eustachian triangle already mentioned, the space between the Eustachian tube and proclavian carotid artery. And after opening this superior second triangle, one can enter the deeper infrapetal clava area. This infrapetal sinus and jugular tubercle and jugular foramen, still covered with the bone. But if one opens the dura, one can expose 7th and 8th nerve and 9th and 11th, and the anterior aspect of the internal auditory canal and jugular foramen. This is a video of the anatomical dissection, the medial nerve here, and the bone. This is root of pterygoid process. This is drilled out and to expose the second tube here. And superior second triangle, this part is occupied with the bone and also cartilaginous segment of the foramen rasculum. The bony segment is drilled out, and as you can see, as the straight instrument can reach the lower pituitary. This is a big advantage. One can approach those areas in the straight line. And here, this is infrapetal sinus. This is also the robust landmarks in this area. And medial to it is a jugular tubercle, and lateral to it is a foramen, jugular foramen or infrapetalous apex. And after opening the dura, the relevant cranial nerves can be exposed, and the internal auditory canal and jugular foramen can be reached. This is done in 0-degree endoscope. So as already mentioned, this approach allows to go into this area in the straight line. And here you can see the foramen rasculum, and this red shaded area has to be transversed. And the major anatomical obstacle is the inferior concha and medial turbinate. So to widen the surgical entry, we performed submucosal inferior turbinectomy and the posterior middle turbinectomy. The mucosa over the inferior turbinate is incised, and the bony content of the inferior turbinate is resected. This kind of surgery is performed by ENT surgeon for severe nasal obstruction. And this is posterior part middle turbinectomy. So invasion to the nasal circumstances is not so big. The root of the inferior turbinate is further resected here, and this is the process is completed. So as you can see, the here in yellow circle, this surgical entry is widened. It's not wide space, but even such a creation of space is very helpful for entering the deeper space in the endoscopic endonasal route. We have measured the area change of infranasal meatus and demonstrated that with this submucosal inferior turbinectomy, the area can be gained significantly. So this is a clinical case. We performed the translational approach. This is chondrosarcoma occupying the left inferior petalous apex. Here, one can trace the course of internal carotid artery and the Eustachian tube, and this is the width of the superior circular triangle can be estimated preoperatively. This is the actual video here. The internal carotid artery and the Eustachian tube, the superior circular triangle can be determined. And now the superior second triangle is opened. At first, the bony content is drilled out. And in the clinical case, the course of the anterior genu, the carotid artery is repeatedly determined not to injure it. Here with the Doppler, and now the ligament of foramen rasum is incised, and already the tumor is exposed. And this is carotid out here. Going further, you can see the petroclavian ligament. Here, lateral to it is jugular foramen. As you can see, the navigator pointer is already reached the jugular foramen. And going medially, the jugular tubercle, the tumor in that area is already removed. This is a final view. The area is cleaned up from the tumor, and the tumor cavity is filled with fat, and exposed carotid artery has to be covered with vital structures such as nociceptor flap, vascular flap. It is very important. Otherwise, the internal carotid artery dry up and can rupture in the chronic phase. This spots up the tumor as growth started removed. And this approach can be also applied for meningioma in the inferior pectoral clavicle area. In this case, the course of internal carotid artery and superior second tube, the superior second triangle is relatively narrow. So again, the course of the carotid artery is determined with Doppler probe and a navigator probe repeatedly, and then the bone is shaped up. Again, the navigator probe indicates the place of the foramen rasum. In this case, the ligamentous segment of the foramen rasum is removed with sonopet, and going further, already the jugular tubercle has been reached, and also the jugular foramen. And the tumor is gradually removed. Here the tumor is dissected from the brainstem, and after dissection of the tumor, the dissection plane is kept with a cottonoid insert, and after that the tumor is removed with a sonopet as far as possible. And here you can see the external nerve. This is almost the final view. Of course, the tumor could not be removed completely, but the tumor extruding into the subarachnoid space can be removed. This is anterior aspect to internal audit canine jugular foramen. The postoperative MRI image demonstrates the decompression of the brainstem. There's some residue in the orbital point, but after 5 years, there's no regrowth so far. So this approach is affected by the configuration of peripheral carotid artery, but I will skip this due to the short of time. As I've demonstrated in the first case, and in the second case, the superior second tube is relatively narrow. So the size of the superior second tube differ among the cases, so I have to estimate this before surgery. So endoscopic endonasal translation approach provides reliable access to the inferior petrous apex. It is indicated alone for lesions confined to the inferior petrous apex, and can be also applied in combination with other approaches for more extensive lesions. Thank you. Thank you very much.
Professor Taniguchi, thank you. Thank you very much for really impressive presentation. Excellent surgery. Do we have any questions from the auditorium? Please, participants, be more active. Okay, so now I propose to move to discussion. Professor Asra, are you here?
Okay, thank you, Prof. Bosnia.
Oh, hello,
Thank
Asra.
you. Okay, thank you, Tanigo Sensei. Yes, very nice and clear presentation. So this is, I think, very advanced approach here for intranasal endoscopic approach. So I just want to ask, in your experience, is there any possible complication related to the approach? This is very important for young neurosurgeon to learn that. In your experience, is there any complication related
Yes.
to the approach that can happen? Please, thank you.
Yes. The most disastrous complication is cardiac injury. So fortunately, I have no case with cardiac injury with this approach. But we perform a balloon occlusion test to see the tolerance. And if the in most cases the tolerance most cases demonstrate the tolerance. So I don't experience a case of an intolerance case. I don't know in such case whether I do the bypass preoperatively, but I think I do not do this. But if I injure the carotid artery in this intolerance case, I go directly process operative to the bypass. So I will prepare for that. But in advance, I would not do that. But what is important is to check the tolerance preoperative with the balloon occlusion test or balloon occlusion test. I recommend to do this.
Thank you. Sensei.
Thank you. Thank you, Professor Azmi. Are you ready to comment?
Yeah, thank you. I really enjoy your presentation, Professor Taniguchi. So I rarely do a paramedian approach because in my center I do together with ENT, and we have a limited instrumentation if you move laterally. So first I want to ask about the exposure of the carotid artery. So after you identify and open the superior triangle, how much ICA you should expose in order to achieve your good removal of the tumor?
Yes, it depends on the size of the tumor. So theoretically, one can approach also not inferior to the horizontal portion of the carotid artery, but also superior aspect of the carotid artery can be approached. But this area can be approached also transcranially relatively easily. So I do not insist on the endoscopy and surgery to go into the area where the transcranial approach can be done easily. But the inferior petrous apex is also very difficult to approach from the transcranial, so I insist on this approach. And how far depends on the size of the tumor, extension of the tumor. And by incising the superior second triangle, this would be started just above the U-second tube, because this is a raw risk to injure the carotid artery. So I already start the incision just above the U-second tube.
Okay, thank you. My second question, if you have a huge lesion, because you demonstrate one case of chondrosarcoma, I think it's a bilateral paramedian. So do you approach one after another, or you approach simultaneously at the same time?
In that case, I did it in one time. And you can do this in both sides because it is the same approach from the nose to the right, from the nose to the left. I did it on one time.
Okay, very well done. And my third question pertaining to equipment, because sometimes when we see the videos, everything looks nice. Do you need any angulated drill or any specialized equipment to cater for this specific para-median lesion?
Yes, for translational approach, this advantage is you can approach in a straight line. So you can do this in the instrument what is already available. But in video with the meningioma, you have seen some articulated forceps. This is not specialized for this translational approach. This is specialized for any kind of Indonesia approach. And so for translational approach, you can do this with a regular instrument.
Okay, thank you very much. I think Ben Ng is raising his hand. Maybe you have a question. Ben?
Thank
yes,
you.
yes. Thank you so much, Taniguchi Sensei, for your great presentation, and also the comment from Professor Asmin. Because I'm also doing in this field, I'm quite interested in your technique. I would like to ask about the first question is, how do you handle the nasolacrimal duct when you do the inferior turbinectomy? So the nasolacrimal duct. So how do you manage it? Yeah. And my second question is that when you do the transurethral approach, for those lesions that is not very lateral in extent, I mean you don't need to open the lateral segment of the ICA. So do you need to remove the ethmoid cell completely, and also the middle turbinate completely to get the transurethral approach? And my third question is about the handling of the sphenopalatine artery. So do you raise the nasal septal fat first, and then to preserve the sphenopalatine artery before during the pterygoid bone, in order to protect? Because sometimes if you don't take the flap first, very often when you drill, you may injure the sphenopalatine artery while you do the drilling of the sphenopalatine foramen. So what is your technique?
Yes, the third question, I raise the flap at first and to preserve the sphenopalatine artery. This is very important to have the vascularized flap. And going laterally, I follow the dissection of the pedicle of the flap, and you can do this. And the first question was lacrimal aqueduct.
Yeah, nasolacrimal duct.
Yes.
Yeah, because
the nasoturbinectomy, submucosal nasoturbinectomy is performed on the medial side, so aqueduct exists on the lateral side. I will not touch this area, so this can be preserved. This is on the medial part of the inferior nasal turbinate. And what was the second question?
About for the transurethral approach with is it necessary to remove all the ethmoid cells and also the middle turbinate to do the extended transurethral approach if the lesion is not that lateral?
Yeah, of course. Yes. If the lesion is not laterally extended, I do not use. But in this case, the transposterior approach is not needed. If I have to do the transposterior approach, this means the lesion is already laterally extended. And in that case, I think I need posterior nasal turbinectomy, middle turbinectomy. Only posterior part, posterior third, not the total middle turbinectomy, only the posterior third. And this widens the surgical space and release the surgical maneuver very easily.
I see. I see. Thank you. Because the reason I asked this question, because sometimes when there is a limited drilling of the pterygoid without removing the hold of a middle turbine, I think it's still possible in some cases. So yeah, thank you so much for answering my question.
Thank you. Thank you too.
Thank you. Thank you. We have one question from auditorium. Dear Professor, thank you for the informative talk. May I know how will you reconstruct the defect if there is a CSF leak? So I mean, I think it's if you have a complication of the surgery and CSF leak, how would you repair it?
Mm-hmm. The second case was the meningioma. In that case, the dura is widely resected together with the tumor. In that case, I plugged the fat intradurally and also extradurally, and the robust reconstruction is the nasal septal plug, which is held with a sinus balloon. And I had so far no major CSF leak so far. So I think it is.
Thank you very much. Great. Thank you very much. So thank you. I think we can move on. Professor Milan, are you with us? I don't see Professor in the list. I don't see. So okay, maybe let us invite.
Yeah.
Yes. Okay.
Yeah, I'm here. Just my video, for some reason, my camera is not working. So, but I'm here.
Sure. Can you share?
Great. So please, can you share your screen?
Yeah.
I want to see your presentation. Please, we are waiting. We cannot see it.
Give me a minute.
Yes.
Can you see it?
Not yes. Please make a full screen mode. Full screen.
Okay. Can you see it now?
Okay. Let me. Yes. So let me introduce present Professor Milan Deogankar from India. He will present his talk dedicated to neuromodulation and its practical use and its perspective for the future. So please, Professor, auditorium is yours.
Okay. Sorry, my camera is not working, but I'm thankful for this opportunity, and I'm very thankful to Professor Kato. I'm a functional neurosurgeon, basically. And I've been working in US for a while, and then also now I'm in India, in Kolkata, in Professor Sengupta's Institute of Neurosciences. Can you guys hear me clearly?
Yes, we can hear you.
Okay.
Yes, we can hear. Please go on, please.
Okay. So I do spinal cord stimulators, deep brain stimulators, brain-computer interface, MRG, FUS, and all these things since 1999, 2000 onwards. And this is one of the fields in neurosurgery that is expanding rapidly. And so I wanted to talk about what is there today and what are the technologies of future. So these are my conflicts of interest. This is where I work now, Institute of Neurosciences, Kolkata. So when we say neuromodulation, we talk about surgical neuromodulation. Now, medicines also do neuromodulation, but we are not talking about that. We are talking about surgical neuromodulation. Surgical neuromodulation includes deep brain stimulation, motor cortex stimulation, spinal cord stimulation, peripheral nerve stimulation, and cranial nerve stimulation. And we do all these things. So I don't want to go in details of how DBS is done because majority of our people probably know that. I'm just going to talk about what's new in DBS. Some DBS methods, DBS devices, DBS indications which are new. Initially, as you all know, the DBS was started for movement disorders, and this was in late 1990s. Professor Benabid did the first DBS. So initially, it was for essential tremors, Parkinson's disease. So thalamus, ST, and GPI were the targets. Then it was started for more movement disorders like dystonia. And then gait disorders, we started putting in stimulators in pedunculopontine nucleus. Then we translated the knowledge we had to limbic disorders. So we started putting in DBS in nucleus accumbens, medial thalamus, area 25 or depression, OCD, Tourette syndrome. Then the same technology was used for doing DBS for pain. And we have done nucleus ventralis cordalis DBS, intralaminar nucleus DBS, and nucleus accumbens DBS for pain. Neuropsychiatric conditions like Tourette's, we have been quite successful in doing DBS. Then epilepsy came, the big SANTE trial came, and anterior thalamic nucleus DBS for epilepsy, which does not respond to anything else and which doesn't have excisable localized focus. We started putting in DBS for epilepsy. And then the indications further expanded to traumatic brain injury. I think this was done in Japan way back. We did a trial in Cleveland Clinic on this and in minimally conscious state. So TBI was one of the newer indications. Obesity, we've done 3 patients as a part of trial with some benefit. Stroke, dentate nucleus DBS for early spasticity or early recovery in stroke. Addiction DBS is going on right now as a form of trial in US and various places. Dementia DBS, attempts have been done for DBS for dementia. Not always successful, but we have done DBS in nucleus accumbens and fornix. So these are all the indications that we do DBS now. So this is actually the present. This is not the future. Also, we have expanded the way we do DBS. We always used to put frame when we started back in late 1990s, and then frameless stereotaxy came, and I think 2002, we started doing frameless stereotaxy. Now it's refined into a patient-specific frameless stereotaxy, much more easier for patients. Also, one of the major parts of DBS is microelectrode recording, and microelectrode recording sometimes is difficult. And so we started doing image-guided DBS. This is the O-arm guided DBS that we did, and we still do. Nowadays, we use O-arm in majority of our DBS, and we also used to do MRI-guided DBS in IMRIS, the MR-guided theater. This way, the things are much more quicker. You don't have to do multiple penetrations, and you get a real-time location of your lead. Of course, on the downside, you don't get the functional benefits or functional improvements in the patient on table. And then the imaging improved. This is one of the 7 Tesla MRIs, parcellation of different nuclei. And I think as the imaging improved and as we started getting the bold fMRI and DTI incorporated in planning, our planning become much more precise and accurate. The leads got better. Now there are directional electrodes. So this image shows this is the STN and this is the internal capsule. With the old lead, everything, the stimulation will spill on the capsule. if your lead is not exactly perfectly located. But with the new split band electrodes or directional electrodes, you can just stimulate part of the electrode and kind of steer the current away from the structures which can cause side effects. DBS is not the only neuromodulatory technique. Nowadays, we use MRGFUS, HIFU, MR-guided functional ultrasound is something we have been using more and more. And for essential tremors, I think this is a very good therapy. You just have to shave the hair and put the frame on and put the patient inside the MRI scan in this. And then make sure the skull density ratio is within a certain limit. And then you target the ultrasound rays to the point where you want to make the sonication and lesion. First, you do low energy sonication so you can see the tremor stops or doesn't stop. And once you are sure that the tremor stops with the low energy sonication, and there are no other side effects, then you can make the high energy sonication and make the lesion. The benefits of this is basically that you can test the sonication without making a permanent lesion, and the effects are immediate. So within 2 minutes, you start getting tremor resolution, and the patient goes home within an hour or two. So DBS is not the only neuromodulation technique. Spinal cord stimulation has also expanded its indication. We always did spinal cord stimulation for pain before, but nowadays we are doing it for motor augmentation, and Susan Harkima's team in Louisville has started this, and we have done some of the patients with Asia grade A paraplegia. We stimulated the conus medullaris to basically get the function back. Also, we doing this in high cervical spine injury for autonomic instability. What is still not there? There are still certain things which are under evolution, and examples are liquid electrodes. We're doing a lot of electrodes outside the brain, like in pterygopalatine ganglion for cluster headaches, sphenopalatine ganglion for cluster headaches. So that area doesn't allow the traditional electrode to sit there. So we have designed some liquid electrodes which you can inject as a gel. Suspended electrode particles and then stimulate from outside. Optogenetics, a lot of people are working on this. Nanotubules, which can be actually injected inside the bloodstream so that they can chemotactically get deposited in the part of brain which you want to modulate. Biological energy harvesting, so no batteries, it will harvest the energy from the body. And then systemic neuromodulation, along with the last one will be cell-based therapies. The optogenetics, you probably all know that optogenetic basically means we put in the vector-based gene, rhodopsin channel gene, which opens up the channels, transmembrane channels, and can upregulate or downregulate a certain cell when a light is put on it. So this is something which is a very good technique, and this has been used in Stanford and some other places for clinical trials. I think this is one of the techniques of future. Nanotubules. So nanoparticles can probably in future have chemotaxis on them, and they can be injected and they can be deposited in the brain. Though we don't have any experience in this, one of my colleagues is working on an animal model of this. But this will be something, again, very, very sleek technique of future. Harvesting body energy, again, this is prototype we have used, and you when you move your hand and the pectoral muscle comes into function, it generates energy. And if the battery that sits on the pectoral muscle can harvest that energy, then you don't need to recharge the battery, or you don't need to basically have a replacement of battery. Not only that, systemic neuromodulation is something which is, I think, going to be the future. Electroceuticals in place of pharmaceuticals. So we've done this for hypertension and congestive heart failure. This is the RIAS system, carotid sinus stimulation for hypertension. This is the wires at the base of the heart stimulating cardiac plexus for refractory heart failure. We've done this for asthma patients, and these are the stimulating stents, bronchial stents, which you can implant in the trachea, and they will stimulate at a certain frequency. So the sympathetic system will be activated. And if someone gets asthma attack, you basically just activate the sympathetic system rather than taking the injection or an inhaler. Same thing in renal hypertension. We can have a stimulating stent intrarenal artery. In erectile dysfunction, you can have basically implantable capsule-shaped stimulators on cavernous nerves. So there is a lot of application outside the realms of brain as we know it, as every organ is controlled by nerves, and the nerves can be modulated by electricity. Thank you very much. And I'm again sorry, my camera is not on, but feel free to ask questions.
Professor Millen, thank you very much. Thank you very much for great presentation, a very inspiring presentation for the future work and the development. Do we have any questions from the auditorium? No, yet not active, but I think we'll have some. So let us move to our discussion. Professor Asra, are you ready?
Okay, thank you, Professor Wozniak. Thank you, Professor Millen, for your, I think, very nice presentation. And I think neuromodulation is the future of the neurosurgery. I just want to ask, I'm not a functional neurosurgeon, but I know that some disease could be treated with this kind of procedure. So I just want to ask if you have experience or you have opinion about this neuromodulation therapy for psychosurgery. Do you have experience, or maybe you have some opinion about the future of this kind of? Thank you. Yeah.
Thank you for your question. We started doing a trial with Medtronic in 2004-5 called Reclaim trial, and this was for depression, severe depression with big depression scores sky high, not responding to medicines, electroconvulsive therapy, multiple suicidal attempts. So those patients we did put in DBS, in nucleus accumbens, because nucleus accumbens is the main node in the PAPES circuit, which is the psychological circuit. And over a period of time, we've seen about 50% improvement in depression. So imagine this is, these patients are so bad that they just cannot live. So for them, 50% improvement is very good. In OCD patients also, we've done a lot of these in obsessive compulsive disorder patients. I mean, again, these are really bad Y-box score patient. They cannot get off the chair, they cannot get out of the house. And after DBS, or even after gamma knife radiosurgery, for that sake, these patients will show improvement in their functionality. It doesn't cure it, but it does make it tolerable for that person.
Okay, thank you, Professor Millen, for your nice explanation. Thank you.
Thank you. Professor Azmi, are you ready?
Okay. Thank you, Prof. Millen. This is very eye-opening discussion presentation to summarize the current development in neuromodulation. I have a couple of questions. Number one, in our country or maybe certain part of the world, the non-communicable disease is uprising that lead to increasing incidence of stroke, for example. So in one of your presentation, you mentioned the role of DBS in stroke. So can you further elaborate how do you predict now in future, whether the role of neuromodulation, the place of neuromodulation in handling or treating or improving the treatment outcome for a stroke patient? So that's my first question.
Basically, we did this in ICE trial, again in Cleveland Clinic, where we stimulated the dentate nucleus of cerebellum. Now, the idea is, whatever is damaged. You cannot really do anything about it by stimulation or whatever you do. But if you stimulate the dentate nucleus, the dentatothalamic and then thalamocortical outputs will increase, and there will be early spasticity in thalamocortical circuits. And that's why you probably will get better recovery. So this was a trial, and we did show in subgroup analysis that there is statistically significant improvement with stimulation, and the time course was less than the time needed for patients without stimulation. Now, again, this is not foolproof. This is something along with physiotherapy, along with neuroprotective agents. This is something which adds to recovery. I think 10%, 15% improvement. So in a country like US, where everything is being paid by insurance and patients don't have to pay for anything, this is a good therapy. But in a country like India, where patient has to pay a lot of money for getting 10, 15% improvement, this is probably not a good therapy.
Okay, thank you. My second question is, in addition to that, we have seen the increasing numbers of obesity. In fact, in my country, we are among the top country with the highest numbers of obesity. Of course, the food are good and people like to eat. So how do you think that the role of DBS or any kind of neuromodulation can be used as alternative to other obesity surgery, and what about the potential outcome?
There are three approaches to this. One we did, one we heard about other group doing it, and one was just a surreptitious result. So we did DBS for obesity, and these patients, we treated obesity as food addiction. So nucleus accumbens is the site for addiction DBS. So we put in nucleus accumbens DBS, and again, it was a NIH-sponsored trial. 3 patients. First patient had very good benefit. The second patient, not so much. The third patient had really bad psychological complications. So then we stopped the trial. That one thing. The second group, there was a group in Italy who has done hypothalamic DBS for obesity. But hypothalamus is such a small structure, and stimulation electrode is 1.2 millimeters. So you stimulate even with 1 volt, you are stimulating 1 millimeter cube area of that hypothalamus. So that is going to activate or deactivate many other functions, which are important functions. So hypothalamic DBS is probably not something I look forward to. But the third one, important one that we found out and we want to work on it, is we put in a stimulator lead in epigastric for chronic non-specific epigastric pain, and kept on stimulating it. And for the pain went away, but the patient lost about 20 kg weight, because epigastric stimulation kept on making him feel that he's full and did not have any appetite, so did not eat. So maybe something like that, which is low tech, is probably a way forward than actually going to brain for DBS for obesity.
Okay, very interesting. My third question is pertaining to the, I think looks like VNS to me, because you shows one picture for treatment of hypertension with one, battery on right side with 2 wires coil on the neck. So probably can you elaborate further the role of, the stimulation? Yeah.
So that was one of the commercially available. It was a trial. It was a new startup called RIOS, and they were stimulating carotid bodies on both sides. So those were around the carotid artery, at the carotid artery bifurcation, those leads. And the idea was, if you keep on stimulating carotid bodies, the hypertensive impulses sent by carotid bodies will reduce and the blood pressure will go down. So we did implant 10 or 15 patients as a part of trial. And I think they published also later on. Their outcomes were not spectacular. They did not come up to the point where they would be, I think, become an alternative for therapy. But there are a lot of targets where you can go. You can go to Vegas. You can go to carotid sinus for hypertension. You can go to renal arteries. I mean, this was one of the animal experiment that we did. We put in stimulating stents in the renal arteries because the sympathetic supply that actually causes renal hypertension and goes to the kidneys is along the renal arteries. So the stent in the renal artery, which has stimulation on the outside and it stimulates the wall of the renal artery, if we keep it there, then it will reduce the renal hypertension. And I think in animal studies, we had good results. I don't think that is translated into therapy in humans yet. But that's one way to go. I mean, rather than taking medicines, why not to just make a lesion when you know it's the autonomic interplay, sympathetic is acting up, then you put a lesion in the sympathetic, or you basically stimulate to make sure the sympathetic things go down. So when you say stimulation, you go beyond a certain point. It actually acts like an inhibition. So sometimes we stimulate, sometimes we inhibit it.
Excellent. Excellent. I enjoyed very much. Thank you, Eddie.
Thank you.
Thank you. Thank you. We
Thank you,
still
thank you.
have no questions from the auditorium. I don't see, but I have some questions. So,
Yeah.
Professor Milin,
Please.
my questions first is like a more philosophical, practical, of course. You know, if we will look at the history of stereotactic surgery, it was initiated completely as a lesional procedures. Then we observed like it almost everything was replaced by stimulations by DPS, and during last decades, so we can see like a restoration of lesional stereotactic surgery, radiosurgery, thermal destruction, freezing, ultrasound, so on, so on, so on. So I'd like to hear your comments about this process and how do you see how they will be coexist in the future, the stimulation and lesional therapy. How do you see in the future? Do they coexist? Do some pathology treatment of some pathologies will be replaced by another method, or they will work together? So what is your option?
Well, very good question, Professor Wozniak. I think this is the rule of life. Whatever goes away comes back. So it's a cycle. Whether it's in medicine or in life, whatever goes away comes back. I think the re-emergence of lesioning is because of advanced methods where you can make a precise lesion and test before making a lesion. Now, personally speaking, I'm a big fan of lesioning. I mean, you want a permanent solution, then you might as well do a permanent alteration rather than something which you have to keep on tuning up every few months. But some also depends on the disease. Like in Parkinson's, when it progresses, you have newer symptoms, then you can tune up your DBS so that it can take care of the new symptoms, and you cannot do that in lesions. I think it depends on three things. First is the disease. If the disease process is kind of fixed, like in psychiatric disorders, like OCD patients, we had so much of problem with DBS because they will keep on picking at the wire and then they will open up. So it's always better to do radiosurgery and get it done with. So it depends on disease. But in Parkinson's, young onset Parkinson's disease, the symptoms are going to become much more different after say 5 or 10 years. So depends on disease, depends on the age of the patient. Again, younger patients are more tech savvy and they can manage the system. The elderly patients, I think it's better to do a lesion and then that's about it. And also depends on the geographical location. I mean, changing a battery and paying for the battery again is such a big issue when patient is doing out-of-pocket payment and there is no insurance coverage. So in those countries where there is out-of-pocket payment and all these things are not covered, I think lesioning does the job very, very well. And I think these two things will coexist. I mean, even back in US, we didn't see any fall in DBS numbers. We just saw when we started doing HIFU for essential tremor. These patients were apprehensive of having a system in their body, so they were not coming for DBS anyway. So these patients came for HIFU. They got benefit. So both those therapies will coexist for chronic pain also. I mean, Professor Jamanod is doing lesions for such a long time, and now he uses HIFU for doing that. I think these two things have to coexist. And in future, wearable stimulators, if they come into picture, that you can wear it on the brain and it will stimulate inside the brain, that will also be one of the options. Injectable stimulators like nanotubules, that will also be one of the options. I think all these therapies will coexist. And now no one is going to replace another.
Okay, thank you. Thank you. And maybe also one small question concerning the peripheral neuropathies after trauma in amputated patients. Something new, maybe, something new, because really it's a tough problem for Ukraine now. We have many patients with peripheral neuropathies. So
Yeah.
maybe something new, except the surgical procedures and nerve stimulator.
I think virtual reality helps quite a lot. If you do virtual reality, the university in Switzerland, they collaborate with a lot of other places. They do this virtual reality where you can see your amputated limb, and that beats with your heartbeat, and then you can touch it, and when you touch it, it becomes from red to blue. I have some videos of that. I didn't put it in it, but that is like a very advanced way of biofeedback, and that helps with phantom limb pain very much. I think for phantom limb pain, virtual reality is good. You have to do like 10-15 sessions of that, but that helps with the pain. Spinal cord stimulation has been shown to be useful in phantom limb pain and neuropathic pain, post-traumatic neuropathic pain. But if you want a less expensive option, probably virtual reality is much better.
Okay, thank you.
Thank you.
Thank you very much, Professor Milind. So may I invite you also as a speaker for my conference? Would you support us in the future?
Absolutely.
Okay, thank you.
Absolutely, I will.
Okay, thank you very much. I will contact you very shortly. I will ask Professor Kato about your email, and I will send you the letter of invitation. Thank you very much. So we are moving on. No more questions, no more comments. Okay, thank you. Thank you. We switching to the next speaker, Dr. Tawassul Ahmad from Sudan. I think he will present a very interesting case of endoscopic removal of impacted suprasellar bullet in the pediatric patients. So please.
Hello, everyone.
Yes.
Hello, everyone. You hear me?
Yes, can hear. We don't see you.
Thank you.
Still.
Yeah, I have some internet connection problem, so I need to shut off the video so I can present.
Okay, please go on.
Okay. Thank you, everyone. Thank you, ACNS. Thank you, Professor Kato. I'm Dr. Tawassul Ahmed. I'm from Sudan. May I share my screen? Okay.
Yes.
I present today a case of impacted cellular bullet in a 3-year-old boy. We operated on him here in Sudan. I'll talk a little bit about Sudan. Sudan is located in the Northeast Africa. And the name Sudan is derived from the word which is belong to a black people. and it's neighbored by different countries like Egypt, Eritrea, Ethiopia, and Libya. The capital is Khartoum, and it is considered the third largest country in Africa, with more than 45 million people and more than 500 ethnic groups. And we are mainly speak Arabic. This is our flag. One of the key factors in our history is the army conflict that started in 2023, 1 year ago. You can see the destruction that happened in the main capital city. During the last year, we received more than 100 cases of penetrating skull injuries. 70% of these cases were gunshot to the brain. About 3 cases were gunshot to the spine. And 10 pediatric cases were in this court of the patient. The youngest was a 40 days female. Her name is Asil. It was a very small shrapnel, lost her left eye, unfortunately. You can see this is different cases and different trajectory of the bullet, different part of shrapnels, complete bullet, arm fell, and there is another neck bullet. We have about 4 cases of the cerebral and supracellular cases region bullet. Removed the bullet in 3 cases successfully. There was 2 patient adult and 2 pediatric cases, and 1 patient developed diabetes insipidus post-operatively. This is the patient. You can see the injury on the right forehead. A pediatric injury in penetrating firearm pediatric injury is a rare condition. Cellular region is considered uncommon region for bullet dislodged there because of its anatomical location, and the challenges in these cases due to its proximity to the pituitary gland, the carotid artery, and the optic chiasm. Our patient was a 3-year-old male. It was an accidental firearm injury. He was sleeping in the backyard of his house, and suddenly he started to cry at the middle of night. And because of the electricity loss, the family did not notice the bleeding. So in the morning, they noticed that there is blood in the bed, and they discovered the area of injury of the bullet. But unfortunately, they came to us after 2 weeks because of the distance and the difficulty in reaching the hospital. The bullet entered mainly from the right mandible. The patient presented fully conscious with a GCS 15 out of 15. There was no neurological deficit. There is no pituitary dysfunction or visual disturbance or any other neurological dysfunction. We did for him CT brain, which showed the bullet which impacted in the cellular region. We couldn't do CTA because it was not available in our region, and ophthalmological examination was normal. Here you can see the CT brain of this patient. The bullet impacted in the cellular region, or the sphenoid sinus mainly. We did for him hormonal profile to evaluate the pituitary gland, and it was within normal. Other investigation was all within normal. We positioned the patient in the Royce position with hyperextension of the neck and elevation of the shoulders, so we can extend and see the heart palate of the patient, because the bullet entered from the right mandible and entered the sella through the heart palate. And we use the mouth gag from the ENT surgeon to retract the mouth, the tongue down, and a patient anesthetized. We enter the cellular region through the entry point from the heart palate, and the bullet removed with minimal destruction around the region. Actually, I was the third person to operate on this patient. He admitted with one of the ENT surgeon and one maxillofacial surgeon. They couldn't remove it, and we removed it in the last. So I was ready for CSF leak. We prepared a fat bath and histoacryl. This is a video you can see. In the beginning, I start to use a 0-degree endoscopic lens, but I couldn't see, so we shift to a 30-degree. You can see that here the polyp is very impacted in the bone with minimal. I try to remove it step by step to make it mobile so I can grasp it and remove it. Here, the edge of the polyp started to appear. And finally, I grasp it with the tissue forceps and it's removed. Post-operatively, we admit the patient for the ICU for 3 days, and the pack removed after 3. In the third days, we monitor the urine output to detect any diabetes insipidus, and we did hormonal analysis for him post-operatively. After we ensure that there is no problem, patient discharged from the ICU, and he received the MOX for DAPS for 5 days. But unfortunately, he developed a fistula between the nose and mouth. After consulting the maxillofacial surgeon, he said we can manage it conservatively. Fortunately, it's closed within 3 to 4 weeks. So, in my conclusion, the endoscopic surgery offers a safe and effective option for removal of a polyp in children because of their small anatomy, and there is an importance for a multidisciplinary team work and advance in planning for these cases, and there is need for a long-term follow-up for this patient for a possible complication. Thank you. This is my team for the last case of polyp extraction and last Wednesday. Thank you.
Thank you, Dr. Ahmad. Very impressive presentation. Unfortunately, in 21st century, we have to manage gunshot wounds in pediatric patients, unfortunately, in my country as well. First of all, I want to have some, I want to ask the auditorium about any questions. No. So I propose to move to comments. Professor Asra, do you have some comments?
Thank you, Professor Bosniak. Thank you, Dr. Tawasul, for your nice presentation about how you manage the penetrating injury. I think this is the ballad, that are penetrating to the brain. I just want to ask about your case. You know that one, most dangerous complication of the penetrating injury to the brain is the infection. Even we already removed the bullets. So do you manage do you manage with antibiotics for how long, or you have any complication of infection in this patient? Thank you.
Thank you for your question. He received antibiotics IV for 2 weeks and oral for another 2 weeks. And fortunately, we keep observing the total and the CRB, and there is no rising in the total or CRB. So he went, fortunately, without any infection.
Okay, because you mentioned in your presentation that the patient developed a fistula after surgery. So I think,
we covered him with antibiotics till the fistula closed. completely.
Oh, okay. Thank you. Thank you, Dr.
Thank-
Tawasul. Congratulations.
Thank you. Thank you. Professor Azmi, have you any comments or
Yeah,
questions?
yeah. Congratulations, Tawasul. This is a very unique approach and very again unique challenge, especially dealing with gunshot injury in children. Because you mentioned that this bullet actually end up in suprasellar. So I want to ask in terms of a technical assessment prior to the surgery, because you know that suprasellar, they have a pituitary, and this suprasellar area is a very confined. You have internal carotid artery, the pituitary gland, the stalk, the hypophyseal artery vessel, and the optic nerve. So what about the pre-operative assessment prior to the surgery for this case? Do you need to do any pituitary assessment in terms of the hormones? And do you need any angiography to make sure that this bullet actually does not get through a critical vessels before you do endoscopic aesthetic and remove the bullet?
Okay, thank you, Dr. Azmi. Yes, we did for this patient, in particular, pituitary profile, hormonal profile for all it was within normal before we entered the surgery. But unfortunately, we don't have CTA here or any angio imaging, so to check the carotid artery. Actually, I was very scared because of the risk of the injury to the carotid artery, but just we did it. But actually, for any patient, we should do a carotid angio to check the carotid artery, and we discuss it with a pediatric endocrinologist for pre-operative and post-operative follow-up. She was with us, and the ENT surgeon and the maxillofacial surgeon all was in the same team treating these patients.
Okay, thank you. My second question again, suprasellar area, usually they have CSF. So in this case, does the patient, the bullet enter into the suprasellar system where the CSF has? So if it has, how do you deal with the CSF leak for this case?
In this case, we did a muscle patch from the fat of the abdomen. We close it with histoacryl, and we use a small cartridge to close the defect. And we pack it for 3 days. And after removal of that, actually, when I removed the bullet, there was a gush of CSF. But we are ready with the patch and histoacryl. So we closed the defect. And after 3 days, there was no CSF leak. Till the patient discharged from the hospital, there was no leak. Just only the fistula that was the main problem.
Okay, my third question is in this particular case, the bullet is only one piece, or they have a multiple shrapnel? If you have a multiple shrapnel, do you chase the small one, or you only remove the big one?
According to the location of the bullet or the shrapnel. Some shrapnel, if it was very deep inside, usually we lift it. But if it is superficial and you can reach it and it is not an eloquent area or dangerous area, we can remove it safely with the C-arm intensifier.
Okay, thank you very much. Very nice explanation and good experience.
Thank you, Dr. Azmi.
Thank you, Dr. Vasul. Any questions? So I have some comments, maybe questions. First of all, I'd like to emphasize that it's a really complex and difficult case. From one hand, you had to operate on this patient, because if you will wait, wait longer, if you could have some complications like carotid wall sore or erosion, some infection, and so on. Of course, the surgery is very risky, but my congratulations that everything finished very good. Unfortunately, we have in my country, we have also quite a big undesirable experience with the penetrating brain injuries. And the general practice, the general rule is we do not try to remove any deep-seated agents. Only we remove only those that are located superficially, and we can remove them from without additional brain trauma. We limit with brain decompression, the treat removal, and then so we never try to remove the deep-seated agents, deep-seated bullets or the pieces of shrapnels in the brain, and limit with antibiotic therapy. So that's all. So thank you very much. And
Ben has question. Ben raised his hand.
Yes.
I'm sorry, I didn't see. Ben, please,
No
I didn't see your hand. Sorry,
yeah, no problem.
Sorry, Ben.
No problem. Thank you, Dr. Tarasu, for this case. Yeah, I also have encountered the problem with the palatal fistula during because of those scalp-based surgery. I would like to ask about how do you handle the feeding of the patients in your setting in Africa? Because like usually like post-op, because sometimes for those with hard palate repair or palatal defect, we might consider to use like desired obturator for the patient to try to start the oral feedings. So in your setting, so I saw your presentation that it took like 4 weeks for the fistula to heal. So during the 4 weeks time, so what is the feeding regime for the patient?
Thank you, Dr. Ben. According to the maxillofacial surgeon, he asked to avoid liquid fluid and use semi-solid fluid and put it in the back of the mouth to avoid the area. So the mother used to train herself to feed the baby without let him the food reaching the fistula. This was it. Okay.
Thank you. So any problem with the nasal regurgitation in your case with that feeding?
Can you repeat the question, please?
Any problem with the nasal regurgitation of the food or
Yeah, there was a nasal regurgitation for in the first 3 days after removal of the back. We removed the back after 3 days from the operation, and the baby started to have nasal regurgitation and for the whole 3 days. Then we changed the food habit and trained the mother. Then the fistula the regurgitation started to decrease gradually over days.
I see. Thank you. Thank you so much.
Thank you, Dr. Ben.
So, okay, thank you very much. Does anybody have some general comments concerning this meeting? Maybe Professor Kato, maybe you have some comments
okay, thank you very much. So, Dr. Wozniak, so nice to hear. And so this is just a collaboration with ICNS ISMINS, the webinars. I think maybe Dr. Azmi will make some short summary about how important also ISMINS treatment for future treatment, I think.
Okay,
thank you
very much.
Yes, very nice webinar. Thanks so much.
Thank you very much, Professor Yokokato. So I also would like to thank the ACNS for giving us a platform to collaborate so that we can deliver the objective of minimally invasive technique in neurosurgery. Actually, whatever approach that we use is not about the size, it's not about how creative we use, but to have an optimum outcome at the same time to minimize tissue traumatization and improve the approach, for the patient. So if you look at all these 3 presentation, they use a lot of this minimally invasive concept as an alternative to other open approach. For example, the last case, endoscope was used, and the first presentation by Professor Taniguchi also, showing that with this endoscope, even on the lateral aspect, by dealing with the appropriate anatomy and equipment, you can deal most of the lesion that used to be not accessible from above. Now with this technology, then we can approach appropriately. And the second speaker also covers the role of neuromodulation, which is a part of alternative treatment, and with benefit for significant amount of patient. For example, like in epilepsy patient, we use VNS and so on. In neuromodulation, you just imagine that a child who presented with 100 times seizure or spasm in one day. So by implementing this technology, so it reduced at least by 50%, and some have a good outcome that make them improve in terms of their quality of life. Although this is a part of palliative treatment, but it benefit for the patient. So I'm really happy that this collaboration works well, and I certainly agree that we have learned a lot from this three presentation, and I must congratulate the CNS, and I must also congratulate all the speakers for participating in this webinar. So thank you very much from me.
Okay, thanks, Asmin. So maybe you can express how important of the endoscope for the minus in future.
Okay, I found
yes. Can you maybe teach INS how important of the endoscopic treatment or surgery? Just Taning Sensei emphasized, please.
Yeah, okay. I first have experience in endoscopy when I went to Germany in 2004, 2005, under the supervision of the late Professor 𝑇𝑟𝑎𝑛𝑠𝑙𝑎𝑐𝑒. So I was really amazed when they start to do a lot of surgery using a keyhole and endoscope. It's actually primary visualization tools so that you can get into cavity, you can get into your target clearly more than ever before when you only do with a microscope. And from then I use that technique. So start with something that doable, like obstructive hydrocephalus. You do transcranial endoscopy just to treat hydrocephalus, do some fenestration, and subsequently I embark on the endonasal approach. Then you can remove a lot of tumors and so on. Then even nowadays spinal endoscopy also are becoming more popular among the neurosurgeon. And nowadays, even part of the endoscope can be mounted to robots. So for young neurosurgeon, I think a lot of things that you can do with the endoscope. But most important thing, you must understand that endoscope has its own limitation too. So it doesn't mean that with endoscope you can do everything, but you need to know what its limitation. And endoscope requires some training. Endoscope require appropriate equipment, and also maneuverability and the selection of the case. I think ultimately, number one is the anatomy, the fundamental knowledge, and get adequate training, and learn from your senior mentor. I learned by watching a video, attending conference, and then if you have the opportunity dealing with the cadaver, that will be very good. And now we have a lot of operative videos, I think shared by most experienced people. This is very important. I think the endoscope is getting more popular, and nowadays I think it's no longer a secondary tool. It's one of the important tools that you should master, especially in the young generation. So I hope that some remarks helpful as a guide to the young neurosurgeon. Thank you, Professor Yoko Kato.
Okay, thanks so much. Okay, so I back to the Bosnia.
Okay, thank you very much. Thank you, Professor Asmi, for very valuable comments. And now I'm conveying our gratitude to Professor Milin, to Professor Taniguchi, to Dr. Tawasul, to our discussant, Professor Asra, Professor Asmi, Professor Yoko Kato, and all the participants of this incredible webinar. So thank you very much. I'm closing and see you next time at the ACNS webinar. They are really, really great events for all of us. Thank you.
Okay, thanks so much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you.
Bye.
先生、ありがとうございました。
こちらこそありがとうございました。失礼します。
素晴らしい発表でした。
失礼します。
Thank you. Thank you.
Hello. Professor Farid, thank you so much. Thank you so much for joining.
Thank you. Thanks.